Hi, everyone. I'm Linda Tintawi, CEO of the Lustgarten Foundation, and I'm very pleased to welcome you to Delivering Point of Care Genomic and Genetic Testing for Pancreatic Cancer Patients and Why It Matters. Breakthroughs in precision testing are reshaping what's possible in pancreatic cancer care. Today, you will hear from two experts about how the latest advances in genetic and genomic testing are transforming how we detect, treat, and manage this disease, and how these innovations are making personalized care a reality for patients. We are anticipating many questions from our audience today, so I encourage you to use the Q&A button below, and we'll do our best to answer them throughout our time together. Please remember that our guests cannot answer questions about a specific case. I'd like to thank today's sponsor, Northwell Health Cancer Institute, for their support. I'm so proud of the nearly 10 years Northwell has supported our mission. To start us off, what do we mean by genetics and genomics in pancreatic cancer, and why it's important to distinguish between these two? Over the past few decades, researchers have learned a great deal about the thousands of different genes inside the cells in our bodies and how they interact with each other, and how many of these genes might be related to pancreatic cancer. Genetics refers to the study of genes and their roles in inheritance. In other words, it's about how genes affect the way that certain traits or conditions are hereditary or passed down from one generation to another. Genetics focuses mainly on the study of individual genes and their effects. Genes are pieces of DNA in our cells that carry the instructions for making proteins, which direct the activities of cells and functions of the body. Genomics is the study of a person's entire set of genes, their genome, including how these genes interact with each other and with the person's environment. On a broad level, genomics is helping researchers learn more about the gene and protein changes inside different cancer cells. This is being used to develop newer cancer treatments aimed at these gene and protein changes. For people with pancreatic cancer, genomic testing of the cancer cells can provide important information, such as how quickly the cancer is likely to grow, as well as if certain treatments, such as targeted therapy or immunotherapy drugs, are likely to be helpful in treating their cancer. And now it's my great pleasure to introduce today's moderator, Erin Billups. Erin is the national health reporter for Spectrum News. She has covered a wide range of topics, from the rollout of the Affordable Care Act to innovations in treatment for diseases like diabetes, Alzheimer's, heart disease, and cancer. Her coverage regularly highlights public policy responses to health epidemics and widening disparities in access to care. Erin is host of Spectrum Network's Exploring Your Health, which takes a deeper dive into major health issues affecting Americans. Welcome, Erin. So pleased to have you with us today.
Linda, thank you so much for having me. And thank you to all of you who are joining us today. We're here to talk about some of the most important advances in understanding and treating pancreatic cancer, especially in the areas of genetics, genomics, and personalized therapy. But before we get there, it's important to take a look at how many people have to confront a pancreatic cancer diagnosis. The American Cancer Society estimates more than 67,000 people in the US will be diagnosed with pancreatic cancer in 2025. Approximately 52,000, more than half, are projected to die from the disease. Pancreatic cancer is the third leading cause of cancer-related deaths in the US. The overall 5-year relative survival rate for all stages of pancreatic cancer combined is approximately 13%. The prognosis varies significantly by stage at diagnosis, which is why today's discussion is so important. So in 2022, my friend and colleague Rochelle Boone died after a relapse with pancreatic cancer. She was a well-known and respected journalist and a wife to Todd Boone and mother to two now teenage boys, Jackson and Carter. And I bring her up because it's so important to remember that the people impacted by pancreatic cancer are not just numbers, and that the disease is felt by all those who love the patient. Jackson and Carter are now much taller than Rochelle was. They're doing well in school. They're having fun with extracurricular sports, soccer and basketball. But I can't help but think Rochelle may have been here to see all of this herself as she developed and received her diagnosis just a few years later, because the science really has advanced. And that's what we're here to talk about today. We're joined by two experts, Doctors Dan King and Jeff Boyd, who can walk us through all the hard work underway that is offering hope that the pancreatic cancer prognosis will be less severe in the future. Jeff Boyd is director and professor of the Institute of Cancer Research within the Feinstein Institutes and is a renowned expert in cancer genetics research and clinical molecular diagnostics. In his roles as Vice President, Chief Scientific Officer, and Director of the Northwell Health's Cancer Institute's Center for Genomic Medicine, Dr. Boyd is focused on developing a molecular diagnostics laboratory designed to deliver point-of-care genomic testing for cancer patients. He fosters Northwell Health's scientific collaborations with academic partners at Cold Spring Harbor Laboratory, where he is a professor, and at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Dr. Dan King is a gastrointestinal medical oncologist based at the Monter Cancer Center and serves as Director of Research and Development for the Northwell Health Cancer Institute's Center for Genomic Medicine. In addition to his active medical practice at Northwell, Dr. King conducts clinical research in partnership with Cold Spring Harbor Laboratory, where he is a clinical scholar in the laboratory of Dr. Dave Tuvson, Lustgarten's chief scientist. Thank you both for joining us. Let's dig right in. So let's start with tumor genomic sequencing. Dr. King, let's start with you. What key mutations or genomic features do you look for when you sequence a patient's tumor?
Absolutely. Yeah. So I'm a medical oncologist. I treat predominantly patients with pancreatic cancer. And now molecular profiling is to the fore. Every first encounter, it's something we need to consider every single time. As some on the call may know, the primary molecular driver that we've identified in pancreatic cancer is in the gene called KRAS, KRAS, KRAS. This is becoming one of the most important genes to test every single time. There are now an influx of clinical trials that are looking at targeted therapy drugs against the KRAS gene mutations. And so it's now become commonplace to test for mutations there. That's not the only one. There are other genes that are frequently mutated in pancreatic cancer, and we are now lots of other clinical trials looking against those targets. Those could be examples such as a gene called MTAP. Many on the call may be familiar with the BRCA BRCA mutations. And so, yeah, this is a new time in pancreatic cancer. The treatments that are becoming available in pancreatic cancer are becoming biomarker driven, and it really heralds, as you mentioned, the dawn of the precision medicine age for pancreatic cancer.
Yeah, and Dr. Boyd, tell us when should genomic testing happen in the process?
It's a great question, Aaron. I think it's fair to say that now the standard of care is to perform a genomic or a complete genetic analysis of every patient's tumor at the time of diagnosis
Mm.
to get at some of the issues that Dr. King was referring to, as well as some others, so that we have all the information we need, all the options are available for effective treatments for new pancreatic cancer patients.
Yeah, and that doesn't typically or traditionally happen. Dr. King, what should patients be asking of their doctors?
Absolutely. And what you mentioned, I think, is absolutely the case. You know, historically, I think it was underappreciated what the impact was for both inherited genetic changes as well as what we call somatic or acquired molecular changes in tumors. Over the last few years, we have seen guidelines change for what we call germline or inherited genetic testing. Now it is universally recommended for every patient with pancreatic cancer to have germline testing done. The way by which that test is not universal across healthcare systems. In some, the patients are referred to a genetic counselor where that inherited testing may be done, and in others, the testing may be provided by the oncologist. Germline testing does come with implications for what positive testing results may have in other family members and whether future cascade testing of other family members needs to be done. But that is all now part of the conversation and should be. That should be part of what patients expect when they see an oncologist is at least a discussion and hopefully testing of germline genetic variation. For molecular testing, historically, molecular testing has been in the realm of patients who have advanced, that is to say, metastatic disease, for patients who've progressed on standard therapies, but this is very much in flux because of this really exciting time we have with new targeted therapy drugs that are starting to prove themselves, starting to show some really exciting data in late line settings. Many, many different trials are now pushing those treatments up front for patients that are previously undiagnosed, which has put pressure and needed pressure on doing molecular testing, as Dr. Boyd said, from the outset.
Yeah. So, Dr. Boyd, I mean, yes, Dr. Boyd, how can genomic testing change a patient's treatment plan? And Dr. King, feel free to chime in after he touches on that a bit.
Sure, yeah, I'll give that a shot. Well, in several ways, and we've touched on this point now a couple of times, the difference between somatic or acquired genetic alterations. It's important to recognize that all cancers, including pancreatic cancer, are in essence genetic diseases. So, in other words, the acquisition and accumulation of genetic alterations somewhere in the genome are what transform a normal pancreatic cell into a malignant pancreatic cell.
Mhm.
So pancreatic cancer is no different than any other cancer in that respect. Now, those mutations are typically acquired in the pancreas, just as in breast cancer, for example, the mutations are acquired in the breast. These somatic mutations that Dr. King mentioned. On the other hand, about 10% of all pancreatic or PDACs, pancreatic ductal adenocarcinomas, are associated with inherited genetic susceptibility, which means the first critical mutation required for the transformation of a normal cell into a tumor cell is inherited from one or another parent.
Mhm.
And it's very important to know whether any of these mutations exist, because often there are drugs that target these mutations. And it's also important to know in terms of the full genetic landscape of the patient's tumor, regardless of whether it's an inherited mutation or an acquired somatic mutation, it's important to know what the mutational profile is. Dr. King's already mentioned KRAS, which is there's an explosion now of clinical trials looking at various forms of small molecules that target the mutant KRAS gene in all its different manifestations. KRAS has historically been considered an undruggable gene in terms of precision or targeted therapeutics, but that's all changed now. And perhaps Dr. King could elaborate on that a little bit.
Sure, Dr. Boyd. And Aaron, it's such a good question. I love my job, but I hate this disease. And historically, it has been so evasive. It's been very intractable. But to Dr. Boyd's point, we are at a watershed moment where we are finally starting to see ways to get at it. Starting about 2 or 3 years ago, we've really come to recognize that the BRCA mutations are something that we could target. What we've learned is that those patients more sensitive to certain types of chemotherapy drugs. We call them platinum types of drugs. And there was a very influential clinical trial called the POLO trial that showed that patients who have BRCA mutations, about 5 or 6% of the population have inherited such mutations, and another 6 or 7% have somatic mutations. So up to 15% of patients have a BRCA or similar mutation. Well, we've learned that those patients with those mutations do quite well with platinum-based therapies and become eligible for maintenance treatment, which with what are called PARP inhibitors. And now we have some trials underway asking whether PARP inhibitors should be combined with immunotherapy drugs and whether PARP inhibitors may play a role in patients who've completed resection of pancreas cancer. So very exciting things that we've seen come to fruition in the last couple of years. That is the first real example of how biomarker-directed therapy has made its impact already in pancreatic cancer. And to Dr. Boyd's point, we're now starting to see this tremendous influx of new drugs. KRAS inhibition is definitely an example. We're identifying, I think it's probably worth saying that the DNA mutation in KRAS causes a cascade of problems within the cell in what's called the MAP kinase pathway, many different drugs below it that investigators have also previously tried to target. But now that we are starting to really get a handle on how to target the KRAS mutations, we're learning about an influx of different approaches, both to target all KRAS mutations and also drugs that are more selective for individual variants, flavors, if you like, of the KRAS gene. Many different clinical trials by many companies there's really an explosion, thankfully, for patients of different assets going after the KRAS drug. The other one I'd like to point out, which I'm very excited about now, is the MTAP loss. It turns out that for our cells to survive, we need a way to recycle certain nutrients. We call them amino acids, methionine being one of them. And our body is dependent on mechanisms to do such a thing. But our tumor cells, which have a loss of a gene called MTAP, have a dysfunctional system that are more reliant on pathways that now we can inhibit, something called PRMT5 inhibitors. So the match between MTAP loss, which occurs in about a third of patients with pancreas cancer, and these PRMT5 inhibitors, again, is leading to an influx of multiple different clinical trials by many different companies. They're developing these drugs that, again, have really started to show some good data in a late line setting, and now we're starting to see the emergence of clinical trials in the early setting and hopefully in the neoadjuvant setting as well. So that is yet another example of a biomarker that is entering its space, and again, reflective of just how important it is to know a patient's mutational profile when trying to select the best precision approach in management of that patient.
Yeah, well, let's dig a little deeper into inherited genetic mutations. Dr. Boyd, what's the difference between a tumor mutation and an inherited mutation that someone's born with?
Great question. And I see that there are a couple questions on the question and answer board related to inherited or hereditary pancreatic cancer, or inherited predisposition to pancreatic cancer, more accurately. The difference is that when one inherits a genetic alteration from mother or father, comes through the egg or the sperm, depending on which parent, and the mutation is essentially present in every cell in the body. And for reasons that we don't clearly understand, depending on the gene, genetic mutations inherited predispose to one or another cancer type, but certainly not all cancer types. There are a handful of genetic syndromes associated with the 10% of PDACs associated with genetic susceptibility, the BRCA mutations that we've discussed, Lynch syndrome, Put-Jaeger syndrome. There's something called familial atypical mole melanoma syndrome, hereditary pancreatitis, which is due to any of 4 genes, and mutations in a handful of other genes that function in a similar pathway to BRCA, including CDKN2A, ATM, and PALB2. That's kind of a laundry list, a shopping list of the types of mutations that can be inherited from one or another parent. And that is the initial rate-limiting genetic alteration, the one that's inherited. The cell is normal until that, in the absence of that genetic alteration. The rest of the mutations are acquired. Cancer is not a one gene or a one gene disease. Additional somatic mutations must occur after that initial inherited mutation gives rise to a mature pancreas. And it's probably no surprise that most cancer predisposition genes that lead to so-called hereditary pancreatic cancer are involved in DNA repair pathways so that they create DNA instability, making it more likely that additional mutations will occur somatically, the acquired genetic alterations, the 4, 5, 6, or 7 mutations that are necessary for a normal pancreatic cell to become a malignant pancreatic cell. And I think it's worth noting that one of the questions that was just asked, what about testing for people with family history,
Mhm.
but not indication yet of pancreatic cancer or even precancer? That's a great question. The greatest risk factor for pancreatic cancer, for again, I'll use the colloquial term hereditary pancreatic cancer, even though you're not born with pancreatic cancer. We sometimes use that term. The greatest risk factor is a family history. So, in other words, if you have 2 or more first-degree relatives with pancreatic cancer, that is the greatest known risk factor for pancreatic cancer. And all of these patients, another listener asked immediately afterwards, when and where can you get genetic testing for pancreatic cancer? In these cases, one's primary physician should refer to a genetic counselor who can. We don't do testing without counseling. That's very important to recognize. It's critical. The standard of care is not to simply order genetic tests. It's to have thorough genetic counseling with a physician, medical geneticist, more often with a trained, certified genetic counselor who can explain the situation very clearly and give the pros and cons of genetic testing before genetic testing is ordered. And the testing is not ordered by patients themselves, but through a healthcare system, through a genetic counseling network to outside laboratories that perform the testing. And there are several of them that do this. And so I can't overstate the importance of getting access to genetic counselors, certified genetic counselors who are all master's degree holding professionals who have been trained after undergraduate school in terms of genetic predisposition to cancer and other diseases.
Yeah, so this is really interesting. Dr. King, can you walk us through how common inherited mutations are, or the different herited mutations like BRCA in pancreatic cancer? And I think Dr. Boyd touched on this a little bit, but what does it mean for both treatment and the family members?
Yeah, the most common mutations that we see that predispose to risk of pancreatic cancer are in the BRCA family. Actually,
Mhm.
BRCA2 is slightly more common as a risk factor in pancreatic cancer than BRCA1, but are as well as a third gene, a different name, PALB2, PALB2, which is a partner of the BRCA gene. Those three, when considered together, do account for something like 5 to 8% of inherited risks. So that is it is certainly a fact. 8% of patients with pancreatic cancer do have a inherited mutation in one of those genes. There are other genes that can be mutated, which certainly confer a risk, in fact, a very high risk of pancreatic cancer, but they're very, very rare. One, to my knowledge, is STK11, which predisposes for hereditary pancreatitis. Pancreatitis, over time, can lead to inflammation and pancreatic cancer. That is usually a condition that is discovered very early in development, in when patients are children, because it causes a whole host of problems, pancreatitis that won't go away. So those are the most common inherited causes of predisposition for pancreatic cancer.
Yeah, so if someone does have these inherited mutations, what targeted therapies or clinical approaches are most relevant for them today, Dr. Boyd?
Well, there's a class of genes that we've discussed that are involved in the repair of double-stranded DNA breaks. They work via a mechanism called homologous recombination to normally repair those double-strand breaks that occur just naturally during the replication of DNA when a parent cell becomes 2 daughter cells. Mistakes occur. You've got to faithfully replicate 3 billion base pairs, and double-strand breaks sometimes occur. And it so happens that the BRCA1 and 2 genes, as well as PALB2 and some of these others, ATM that we've mentioned, are responsible for recognizing and repairing those DNA double-strand breaks. And there's a particular class of drugs that Dr. King has already mentioned called PARP, capital P-A-R-P, which stands for an enzyme. It's a little too dense to get into the name of the enzyme, but the point is PARP inhibitors um, work in a fashion known as synthetic lethality in patients whose tumors have a BRCA2 mutation, for example, to kill the tumor cell much more readily. And so PARP inhibition has been a big breakthrough in terms of patients with some of these inherited genetic alterations, in addition to the KRAS genes that we've discussed that occur somatically. And I would say that in terms of genetic predispositions, it's not just um, treatment that's relevant here for the affected patient. It's important to remember that these genes are typically functioning in a Mendelian dominant fashion. That is, when a parent carries one of these mutations, there's a 50% chance that all of the offspring will inherit that mutation. And so if a patient is carrying a mutant, let's say, for example, BRCA2 gene, then there's a 50% chance that if that patient has kids, 50% of those kids, half of them will have a genetic alteration, siblings, aunts, uncles. It's important to consider the entire family. And that's why counseling is so important. And we can sometimes perform in unaffected individuals. This question has come up on the question and answer board. We can test, it's called cascade testing, when unaffected family members are tested. When a patient is known to be carrying one of these genetic alterations, because screening is actually something that can be performed in unaffected individuals. And Dr. King might want to say a few words about some of the screening. He's done some work in this area, some of the screening tools that are available to look at unaffected individuals who may be at very high or significantly increased risk for pancreatic cancer because of an inherited mutation.
Yeah, what is the process? So if you are at higher risk, does that mean you're getting checked more frequently? You're getting screened more frequently every 3 to 6 months? Like what's the process for folks once they go through that genetic counseling, they realize that yes, maybe they have these inherited mutations, Dr. King?
Yeah, I can take it. It's such an important topic. For patients that we believe are at increased risk of developing pancreatic cancer, for example, patients who do have germline BRCA mutations, these patients really should be seen at large healthcare systems that have the capability of doing and the expertise of doing regular screening checks. The way that we do this now is alternating at 6 month interval MRI and endoscopy. So an imaging test as well as an endoscopy, a camera to look in the pancreas to see if there's anything unusual happening in the pancreas. For example, this a new mass that's forming. We desperately need better screening modalities for pancreatic cancer. As I just answered in the Q&A, I put in an answer to one of the previous questions about screening and where we're heading. There are many other cancer types out there, colon cancer, skin cancer, breast cancer, cervical cancer, prostate cancer, that have screening tests already. We do not have a screening test in pancreatic cancer that has proven itself. A screening test needs to be able to find very limited amounts of disease. It needs to be very specific. So there are very few false positive tests. There are other characteristics that make a good screening test. It needs to be convenient, it needs to be inexpensive. We need desperately the development of a screening test in pancreatic cancer so we could take patients, perhaps those who are at increased risk, and whether there's any signs or any early signs that a pancreatic cancer may be forming. Because, as I tell patients, there are two ways that we're going to cure this disease. We either develop drugs that are so good they can destroy the cancer even if it's spread. Okay, an example of that would be like antibiotics for bacterial infection, right? If we could do that for pancreatic cancer, we'll cure it. The other way is we find the pancreatic cancer early enough that it's in one little spot and we destroy it before it has a chance to escape and spread. Right? So those are our strategies. An early detection initiative using uh, blood tests, perhaps, that can find very early signs of pancreatic cancer so it could be destroyed is really a critical need. And as I mentioned, is type of research that Lustgarten is funding.
Yeah, actually, a question just came up about, is AI being used to help, you know, detect early pancreatic cancer yet? Or are we still at the stage where the tests are finding these mutations, but they're not confirming whether or not they will actually progress onto actual disease? Yeah.
Yeah,
Either one of you can jump in on
I'd
that.
love to take this. Yeah, I'm happy to
This,
start.
this is for Dr. King.
Uh,
He's an AI
Okay.
this is my jam.
aficionado.
Okay.
It's such an important topic, and under, Dr. Boyd's mentorship, I've really started to think a lot about how to tackle AI and early detection, early interception of pancreatic cancer. I think there's a few opportunities that are really exciting. One is an intervention unleashed in our healthcare system in Northwell Health. So actually, we've deployed an AI model that every day is flagging patients that have new masses in the pancreas, and the objective of that is to see if early and proactive healthcare delivery for patients that have new masses, if we could proactively have pancreas cancer specialists reach out to such patients with a mass and pull them into clinic, pull them into care so that those patients could be screened for clinical trials, they can be consented for biospecimen studies, they can be expedited in their biopsy and workup, they can see an oncologist right away. Is that expedited care delivery something that could help improve outcomes? That's definitely something that we study. I would say beyond that, there are many factors that we should be able to mine for in the electronic healthcare record systems of
Mm,
our institutions to find patients who may have very early signs of pancreas cancer. And examples of that could be new onset diabetes, especially if there's weight loss. The reason for that is because new onset diabetes is pretty common, but new onset diabetes in the setting of weight loss is not so common in the general population. Cancer eats up calories. So patients who are losing weight, but developing pancreas cancer, that is something that is much more specific in the development of pancreatic cancer. So if we could mine EHRs, find patients who are meeting those characteristics, and then consider an imaging test or a blood test to see if there's any evidence of cancer, that could be a strategy where AI has access to large data sets in large healthcare systems and then is again sort of proactively pulling patients who may be at these increased risk, have these increased risk factors to have early testing done. So again, we could potentially find and eradicate the disease at very early stages. Yeah.
yeah. Wow. So, okay. So, Dr. Boyd, let's talk about next generation sequencing. How is that progressing? Explain what it is and how that information might be able to directly shape a patient's treatment.
Yes, great question, Aaron. So at the beginning, we talked a little bit about the difference, or you talked a little bit about the difference between genetics and genomics. And it was a very lucid sort of explanation and distinguished the two very well. I like to consider genetics, as I mentioned earlier, a way of thinking about cancer, having been a cancer geneticist and more recently genomicist for my entire career. And genomics, a set of tools that, if used wisely, can serve the patients we serve, not only with pancreatic cancer, but other cancers as well. Now, that leads me to your question of next generation sequencing. Genomics is a set of tools, which implies that we're looking at many genes at once. We can look at the entire genome, which remarkably, as recently as 2001, when the Human Genome Project was essentially completed, It was an 11 or 13-year project, depending on how you count, beginning in 1990, performed by the US government. So that was a 13-year project that cost about $3.3 billion to sequence one human genome. And now in 2025, we can, in the laboratory that I direct here at Northwell, if we chose to, we could sequence one genome in a couple of hours for several $100s, which gives you a sense of the progress we've made in terms of getting from sort of understanding genetics at the single gene level and what does a gene do and how does it do it and how is it mutated, to looking at the full architecture, genetic architecture of a patient's tumor. So that is information, genomics, the human genome we now have at our disposal. And how can we mine, how can we manage all of that information? And the answer is through next generation sequencing. It's through technology. How did we get to the point where we could go from 13 years and $3 billion to several hours and several $100s to sequence a single human genome? It's through a technology known as massively parallel or next generation sequencing. It occurs in a large box about the size of a small refrigerator. And one simply takes the DNA, the genetic material, and sometimes the RNA, if we're looking for fusion mutations, which we typically do, and purify the nucleic acids, the genetic material, insert that material into the next generation sequencer. And I don't want to be flip about the issue, but essentially a miracle occurs, and in 2 or 3 hours, you've got the sequence of hundreds, thousands, whatever panel you choose to run of genes at your disposal, and we can generate a molecular pathology report on the genes that are mutated, along with the drugs that are FDA approved for those specific genetic alterations, drugs that are approved off-label, that is to say, in another cancer type for those specific genetic alterations. And then in the fourth column on page 1 would be clinical trials. For example, clinical trials going on with the KRAS gene and PDAC, for example. And we can deliver that molecular pathology report through the electronic medical record to the ordering clinician, and he or she can then make decisions based on the genetic architecture of the patient's tumor. All this can occur within a period of days. And it's really transformed as we've been talking up to this point, it's really transformed having that knowledge at your fingertips. The treating clinicians like Dr. King, GI medical oncologists, but also surgeons and radiation therapists, radiation oncologists, I should say, who are also involved in the treatment of pancreas and other cancer types, to have that genetic architecture of a specific patient's tumor. Every tumor is different. Not only are pancreas tumors different than breast tumors that are different from brain tumors, but any two pancreatic cancer tumors are different from one another at the genetic level. And so it really is a personal disease in many ways, defined by that genetic architecture, which is informed by next generation DNA sequencing, which I can't overstate how has really transformed the field in terms of understanding the origins of the cancer and allowing us to screen family members in the hereditary context, and allowing us, in some cases, not all, but in some cases, to treat based on specific genetic alterations.
Yeah, it's really remarkable where the science has, how far the science has come, and I'm gonna try to bring together some of the questions that I'm seeing. People have histories of pancreatic cancer in their family, but they also have histories of other cancers in their family. They may not have the two immediate relative sort of connections to pancreatic cancer. Um, so, what have we learned from genomic studies that might change how we screen people to catch people with pancreatic cancer earlier, because we know about mutations that might have led to breast cancer or something else in another family member that puts them at heightened risk? Do you see the future of screening changing uh, to widen the net per se? Dr. Boyd, you can start with that, and Dr. King, feel free to jump in.
Yeah, absolutely. Happy to. Yeah, when I began my career in inherited cancer genetics, the BRCA1 and 2 genes hadn't been discovered yet. So I'm dating myself. But the point is that we originally thought that these were, well, BRCA was named as such for breast cancer. It was thought to be a breast cancer susceptibility gene. We've since learned very quickly that it's that both genes predispose to breast and ovary cancer. They're now known as genes that cause the breast and ovarian cancer syndrome, which is now also an outdated name for the syndrome because we know that, as we've discussed, BRCA2 especially, but also BRCA1, predisposed to pancreatic cancer and prostate cancer, for example. Prostate cancer patients, metastatic castrate-resistant prostate cancer patients should all be screened for genetic predisposition. We know there are other syndromes, such as Lynch syndrome, which predisposes to genitourinary cancers, to other gastrointestinal cancers, and to gynecologic cancers. Also places family members at not incredibly high, but significantly increased risk for pancreatic cancer. We both, Dr. King and I have both mentioned now um, genetic predisposition to pancreatitis, which is a major risk factor for hereditary pancreatitis would be a major risk factor for pancreatic cancer. So, Dan?
Yeah, I don't have too much to add. I think one thing that we're seeing is we are always learning whether the individual parts of genes are truly uh, deleterious, meaning damaging, meaning likely the driver of cancer. For example, these genes, right? And if you want to imagine a gene as a book and the book has many, many letters in it, we don't know the impact of every individual letter change, every typo on the likelihood of developing cancer. And in part, our ignorance on this topic is unfortunately hindered by by the by previous studies that sometimes neglected to enroll participants across many ethnics and ancestries. And so I think we've learned that over time, and we've done a much better job building reference sets that are inclusive of many populations so that we can have a better understanding of the breadth of different genetic changes and whether genetic changes may predispose to cancer. And over time, I suspect we will continue to learn and broaden our understanding of what mutations are truly predisposing. In fact, not only the variants within any gene, but also the number of genes, other genes that we're now testing for, as our panels include more genes. I think it will also contribute to a better understanding of which genes and their mutations are truly predisposing.
Yeah, let's actually zoom in a little bit more on KRAS mutations, Dr. King. It's come up a lot today. It comes up in almost every discussion of pancreatic cancer. Can you go down the rabbit hole a little bit? What is KRAS? Why is it so central to the disease?
Absolutely. One thing I was mentioning a little bit earlier is that these genes don't exist in isolation in the cell. Our body needs a machinery to tell cells when to grow, when to divide. It is an important part of our physiological normal nature. The challenge is a genetic mutation, a change occurs that changes the instructions in the gene. And one might think of a gene almost like a light switch. And the body needs that light switch to turn on and off and on and off. There are times when we need our cells to grow, and there are times where we don't need our cells to grow, where we need them not to grow. And basically, the KRAS mutation is a good example of a hijacking, rewiring of the cell so that the processes that say grow they don't turn off. That's really the problem, is that KRAS mutations tell the cell to stay on and keep growing. So it's your own body just telling itself to grow, 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 grow. The KRAS gene has, if you like, different functional components within it. And if you want, you could again think of it as sort of the part that tells the switch to stay on is one of its components. And so many people may know or have heard of something called a KRAS G12D mutation. What does that mean?
Mhm.
Right? So we can think about the so-called codons, the amino acids, the different components of the proteins that are made from the genetic material. And it turns out that one of the functional domains, the switch part, is impacted very, very commonly from a mutation in one spot, and that's this 12 amino acid spot, the codon spot. And G and the letters that are sometimes being, many of the people on the call may have heard of these letters like G12V, G12D, right? They just refer to different amino acids that are made from the genetic instructions. So a DNA change leads to a change in amino acid, and those amino acids have a great bearing on whether that light switch stays on or off. They also have a very important impact for how to design treatments. All right. So not in pancreas cancer, but in lung cancer, there's also KRAS mutation. And it turns out there's a preponderance of a different type of mutation, also at the same location, but but it changes to a certain type of amino acid called a cysteine, which has parts on the outside of it, these sulfur atoms that are sticky. They're sticky. All right. So it turns out the first generation of KRAS drugs were created mostly for lung cancer, where they learned how to leverage that sticky nature of the cysteine amino acid. So that was kind of a breakthrough moment. But it started for scientists to learn much, much more about this pocket that's available, this switch pocket that's available at this 12th location. And after that, scientists have gotten much, much better at learning how to stick things to it. So we have what are called the tri-complex inhibitors, which is a way of using a molecule called cyclophilin as what's affectionately called as a molecular glue to be able to prevent this KRAS, mutated KRAS gene from affecting all the later cellular pathways. And little by little, scientists have discovered different ways of going after all the unique flavors of mutations, both at this 12th position and the 13th position, the 61st position, and these other positions that seem to tell the switch to stay on. What's been really exciting now is the development of drugs that are agnostic to the exact location, but regardless of the location, if that KRAS gene is overactive, they tell it to turn off or they degrade the product from another, many, many other mechanisms. So that's a little bit more detail about the KRAS gene, its components, and how scientists are trying to target it.
Yeah, it was super exciting. Okay, so we've been hearing you guys mention personalized treatment a lot based on everything that we've discussed so far. Uh, Dr. Boyd, you could start with this. Where are we right now with true personalized care in pancreatic cancer? And where do you both see this going in the near future, most immediately?
Yeah, you seem to come up with great questions every time. Aaron, thank you for that. We've talked a lot about we've talked about inherited predisposition and some of the ways we can leverage that, both in terms of targeted therapeutics and in terms of prevention through cascade testing of family members or unaffected individuals of any kind carrying a mutation. But in terms of somatic mutations, acquired genetic alterations in, for example, KRAS, it's really difficult to overstate the excitement, the importance that's come over the past couple of years with the development by pharmaceutical companies of that always begin in the lab somewhere at one or another research institution. The importance of the development of small molecules that recognize the critical region of the KRAS protein that causes it to be stuck on. As Dr. King mentioned, we want to turn it off. It's like a light switch. You want to turn it off and prevent the cells from proliferating. And the development of additional small molecule drugs that recognize these various forms of mutant KRAS is probably the most exciting development in pancreatic cancer therapy to come along um, in the history of treating pancreatic cancer. Now, what's the future was the essence of your question. So it's clear, not just from pancreatic cancer, but from treating other cancers as well, that knocking out one of them, remember I said that all cancers are the result of multiple genetic alterations, driver mutations. You need more than one for a normal cell to become a cancer cell. And as it turns out, you can stop cancers from growing for a period of time. The time period differs from one cancer type and one mutation type to another, and the type of drug that's used. But inevitably, almost always, the cancer will find a way. Cancers are very Darwinian. They find a way to evolve around the targeted therapeutic that's, for example, targeting KRAS in a pancreatic cancer, and the cancer will recur. So the future is understanding the genetic architecture of a particular cancer and having drugs that target additional genetic mutations so that we can target two genes or perhaps even three genes. Then the mathematical models that have been developed, the computational models, suggest that cure is in fact possible when we can shut down two or three genes rather than just the one. And the cancer can no longer figure out a way to get around the inhibition of a particular mutation with one single specific drug. And so that, I think, figuring out how to drug TP53, which is a very common mutation in pancreatic cancer, SMAD4, CDKN2A, it's a rather monotonous tumor in terms of the genetic profile. Those are the four genes, KRAD, that I mentioned that are present in most all pancreatic cancers. And when we can figure out how to drug two or perhaps three of those genes, then I think that's where we'll really start to see remarkable improvements in terms of long-term survival. I still won't use the word cure. I was raised as a scientist not to use that term in cancer for advanced metastatic disease, but I think extremely long-term survival is a very real possibility with with our newfound ability to target more than one mutant gene in a particular cancer type.
That's fantastic news. Dr. King, do you have anything you want to add about the future of care as you see it?
I think Dr. Boyd really hit the nail on the head. These drugs, the RAS inhibitors, are looking very exciting. On the other hand, we do not expect that any one of these RAS drugs is likely to be curative on its own. We think that probably be prepared for how the pancreas cancer learns to pivot and develop its resistance to these mutations. And it may, in fact, be the combination strategy with these RAS inhibitors and other either biomarker selected options or other drugs likely to impact the most common resistance mutations when given together are going to lead to better outcomes. I think that's certainly the thing. This is the dawn of immunotherapy in pancreas cancer as well. We are finally learning how to leverage the immune system against pancreas cancer, albeit not so much with checkpoint inhibitors, but with vaccines. Some of the very, very exciting work out of MSK with the Genentech vaccine for resected pancreas cancer is starting to show some really early but very promising data in reducing relapse rates using these immune therapies. Very exciting work there too. And really the whole gamut. Targeted therapy, immune therapy is a bright future ahead in pancreatic cancer, really a watershed moment in some of the new treatments that are now coming down the pike. And I'm just honored that I am getting to witness the emergence of all these new treatment options that we're starting to see for patients with pancreatic cancer.
It's truly remarkable. And um, hopeful. And I see a lot of people commenting about worry about family members and making sure that they can get them screened. And it looks like the technology is heading in the right direction with that. Thank you both, Dr. King, Dr. Boyd, so much for sharing your expertise with us. What I would say is it's clear more funding for this very important research is absolutely needed. And, as a journalist, I would just say to everyone, don't be afraid to share your stories, your personal stories about this, because the more people know about it, are familiar with it, the more funding heads towards those areas. And this is a very important area for funding. So thank you, both Doctors Boyd and King. And Linda, I'll pass it back to you.
Thank you all for a wonderful, insightful, thoughtful conversation. For our audience who are watching. Clearly, many of them are family members. So I want to thank Dr. Boyd for being so clear about what it means to be at higher risk. That's two or more family members with pancreatic cancer or a known gene, such as the BRCA1 or BRCA2, and then what to do. And I think the point about the genetic counseling is very important for our audience. And then what we always say at the Lustgarten Foundation, where you're treated matters, which means that, look for an academic medical institution that has genetic counselors on staff and they can refer you appropriately. So you can ensure that if you are indeed high risk, that you are then screened into a high risk program specifically for your type of risk. So really important, very insightful. I want to thank Dan has been doing so much work with artificial intelligence. I mean, if you think about that, looking into the medical records for that weight loss, that's the type of earlier detection that we're really looking for, not just early, but earlier, where we know if you're found early, patients do better. The Lustgarten Foundation has been funding Elliot Fishman at Johns Hopkins for years, applying artificial intelligence to CAT scans. So we know that the AI will actually find the tumors at a much higher rate than even the most skilled radiologist. So what you heard today is how are we pulling all of this together? And you can see how hopeful this is and how much work has gone into this. And Aaron, thank you for pointing out the need for funding. And the Lustgarten Foundation deploys our community's fundings efficiently, effectively, and we are so looking forward to the future and to what will be available for patients and to what Dr. Boyd and Dr. King said. We know the KRAS drugs work for many patients, not all patients, but then based on the sequencing, what drugs could we then add and add and add to give patients even better options? So again, thank you all for this terrific, insightful conversation. And to our audience, thank you. Thanks to people like you who are watching today, 2025 has been a remarkable year for the Lustgarten Foundation. We've made significant strides in pancreatic cancer research, and we believe the year ahead will mark a pivotal turning point in our mission to transform outcome for patients. I hope you'll join us for our next Lustgarten Live on January 27th for an exclusive update with Lustgarten's Vice President of Research, Andy Rakeman, our Chief Scientist, Dave Tuvison, and Chief Medical Officer Liz Jaffe, as they share their insights into groundbreaking advancements and the exciting road ahead in pancreatic cancer research. So check your inboxes in January, and we'll see you then. And happy holidays, everyone. Thank you for your commitment and support of the Lustgarten Foundation. And again, to our panelists, thank you so much. Thanks, everyone.